And now we're moving right along to the pharmacology section of the musculoskeletal chapter. It's a lighter section compared to other chapters, but the drugs here are extremely board relevant, so you should spend some time getting to know them pretty well. Before we can understand how the drugs work, let's first look at the arachidonic acid pathway to understand normal physiology. Though it might take a little extra effort, memorizing this pathway should prove pretty high yield, and it tends to be one of the more often tested pharmacological pathways because aspirin, NSAIDs, and acetaminophen all affect it in some way, and they're also all really common drugs. So let's go through it together, and I'd also recommend copying it down as we go. So let's start at the beginning. Where does the whole process start? The plasma membrane of any of the many different cells in the body. A single membrane lipid is taken by phospholipase A2 and is converted to arachidonic acid. With this arachidonic acid, there are two directions to go, either down the lipoxygenase pathway or the cyclooxygenase pathway. The lipoxygenase pathway is simple. AA is ultimately converted into leukotrienes, including LTB, C, and D. Do you recall what LTB4 does from pathology? Neutrophil chemotaxis. LTC and D are really potent bronchoconstrictors. While you won't see these again until the respiratory lectures, the drugs Xylutin, Zafirlukast, and Montelukast all block the lipoxygenase pathway. And it tends to be a really effective treatment option to prevent bronchoconstriction in patients with asthma, especially if the asthma happens to be aspirin-induced. So to help you remember these drugs, just note that they all contain Lu in their names. The second pathway that AA can take is the cyclooxygenase pathway, or the COX-1 and the COX-2 pathway, which convert AA into three molecules. The first two are in some sense mirrors of each other. Prostacyclin, or PGI2, decreases platelet aggregation and also vasodilates. Alternatively, thromboxane increases platelet aggregation and vasoconstriction. One way to remember thromboxane increases platelet aggregation is in the name. Thrombo is the root for thrombus, or clot. How do these two molecules function in the body together? They balance each other. They ensure that vascular tone is always being regulated appropriately, as is the appropriate activity of hemostatic pathways. The third product is prostaglandins, like PGE2. These have a wide variety of effects, including decreased vascular tone, increased pain sensation, and increased uterine tone. Can you guess which of these three molecules is responsible for menstrual cramps? Prostaglandins. They increase uterine tone and are responsible for cramping when the uterus sloughs. Many drugs affect the COX pathways, namely NSAIDs, acetaminophen, and aspirin, which are all nonspecific and block both COX-1 and COX-2. There are specific COX-2 inhibitors that allow the COX-1 pathway to remain intact, which we'll talk about in just a few minutes. Corticosteroids, on the other hand, also function to block both arms of this pathway. What do they work on? Phospholipase A2 activity, and also the protein synthesis that creates the enzymes COX-1 and COX-2. By doing so, steroids can also be potent anti-inflammatory drugs. Let's have a quick flash quiz. Where does the arachidonic acid pathway start? In the cell membrane, with a single phospholipid that is processed by phospholipase A2. Good job. Another commonly used drug for analgesia and antipyresis is acetaminophen. How does acetaminophen work? It reversibly inhibits COX in the CNS, but not in the periphery, where it's made completely inactive. Therefore, since it can't get to the sites of inflammation directly to block COX, it also has no anti-inflammatory effects, and is not technically an NSAID. However, children with fevers benefit from this drug. Their fevers come down, and they also avoid the risk of Ray's syndrome. Acetaminophen is notably metabolized in the liver. What is metabolism dependent on? Glutathione, which normally neutralizes the toxic metabolites of acetaminophen. If too much is ingested, glutathione stores are depleted, and toxic hepatic necrosis can result, which can be totally life-threatening. What can you do for patients who took too much acetaminophen? Well, the antidote is N-acetylcysteine, which is responsible for restoring normal levels of glutathione. Do you recall from the respiratory chapter the use of N-acetylcysteine? Yeah, it's used for patients with cystic fibrosis as mucolytic therapy. So, what is the toxic acetaminophen metabolite? If you guess NAPKI, you're correct. Okay, based on our discussion, let's do a little quick recall. What does aspirin block? Cyclooxygenase. However, it's important to recognize that aspirin does so by irreversibly inhibiting it by covalent acetylation. What's the result? This reduces production of inflammatory mediators like thromboxane and prostaglandins. How long do you expect aspirin to affect a patient's bleeding time? It lasts up to 7 to 10 days. In other words, the time it takes for the body to replace those platelets. So, should you do an elective surgery on a 50-something-year-old man who's on daily aspirin? No, don't do it. Just wait a week until his platelets are back in action. The interesting facts about aspirin actually come from the fact that at different doses, it has very different effects. At the lowest doses, it is responsible for decreased platelet aggregation, which is important prophylactically for people at risk of heart attacks. So, what about at higher dosages? The second dosage level is intermediate doses, from 300 to 24 milligrams a day, which help to prevent fever and pain. The highest doses are actually required to decrease inflammation in the way that we'd need if there was a concern about a potent inflammatory response. So, what are the side effects of aspirin? The concerns with using aspirin are not trivial, despite the fact that it is such a commonly used drug. The most common is probably gastric upset, which can predispose to gastric ulcer formation, and that can lead to upper GI bleeding. Also, aspirin has a complex relationship with the kidney during excretion, and aspirin use can predispose to acute renal failure, as well as interstitial nephritis. What should you worry about when giving a child aspirin during viral illness? For example, Ray's syndrome, which is marked by neurologic disease and hand wringing. Do you recall when is the only time to use aspirin for children? That would be to treat Kawasaki disease, where the benefits greatly outweigh the risk to treating. In this case, the risk of developing coronary aneurysm, which you can see here in this x-ray, greatly outweighs the risk of developing Ray's syndrome. Aspirin is also known to cause tinnitus, or a ringing in the ears in some patients. Alright, let's do a flash quiz. When is the only time a child should receive aspirin? The answer is in Kawasaki disease, to avoid formation of coronary aneurysms. The COX-2 inhibitors are an entire class of drugs, but in America, the only one that's still available on the market is Celecoxib. The goal here is to specifically reversibly inhibit COX-2, but to keep COX-1 levels normal. Why is this important? The idea is that COX-1 is an important mediator of GI ulceration and eventually bleeding when it's inhibited. It's a common reason to discontinue the use of NSAIDs. So, this is an attempt to selectively block COX-2 and decrease that side effect. COX-2 is also the isoform that is thought to be more responsible for inflammation and pain anyway, so that is the more important one to block regardless. What about the effects on platelet function? Celecoxib does not affect thromboxane production. Why? Because thromboxane production is dependent on COX-1. Clinically, patients with a history of gastritis or ulcers that otherwise can't take NSAIDs may benefit from COX-2 inhibitors, especially if they have chronic conditions like OA or RA. These are generally the only diseases for which COX-2 inhibitors are prescribed in the US. So what can go wrong with COX-2 inhibitors? There's a serious risk of thrombosis. Also, these are sulfa drugs, so patients with a sulfa allergy definitely shouldn't take them. The next category of drugs is a big one. There are many NSAIDs, but you should be familiar with ibuprofen, naproxen, and indomethacin, as well as ketorolac. What is the major difference between NSAIDs and aspirin? NSAIDs cause reversible inhibition of COX-1 and 2. The uses, therefore, are very similar, with antipyretic, analgesic, and anti-inflammatory uses, but not as much of an antiplatelet effect. What is indomethacin classically used for in pediatric patients with a machine-like murmur? It's used to close a PDA when it's open. The downsides to taking NSAIDs, like aspirin, are also not trivial. The common concern is GI distress with ulcers, and also, similarly, with renal damage due to a disturbance of renal vasculature and changes in the native prostaglandin levels. Which anti-inflammatory drug is contraindicated for patients with a sulfa allergy? Celecoxib, the only COX-2 inhibitor available in the US. Next, we'll look at an important drug group in the treatment of patients with osteoporosis. Bisphosphonates are a relatively new class of drugs and have a lot of members, including pimidronate, alendronate, and others ending in dronate. The idea is that these drugs will inhibit the activity of osteoclasts. What do you think the effect is? To decrease bone resorption. Clinically, they've been very effective for postmenopausal osteoporosis and have reduced the risk of fractures at multiple sites in the body. These drugs can also be used in other diseases, namely malignancy-associated hypercalcemia and also Paget's disease of the bone. So how are these drugs going to be tested? Most likely on the side effects. And the side effects are totally classic. As with many drug classes, there are non-specific side effects like nausea and diarrhea. But more importantly, you can see corrosive esophagitis. What should you remember for these patients? Take pills around meals, and also to remain upright for some time after ingestion to help prevent this uncomfortable side effect. What about osteonecrosis of the jaw? Osteonecrosis of the jaw can be a result of bisphosphonate use. This is a pretty classic side effect. Let's have a flash quiz. Does rheumatoid arthritis improve with activity? Yes! And running stiff joints under warm water also helps. It's osteoarthritis that improves with rest.